to the post-lunch session on economics of bridging technology with healthcare. I invite Professor Professor S. Venkat to give a brief introduction about this session.
Good afternoon, everybody. I think post-lunch session is not that easy. And I am Venkat Venkat from IIM Lucknow. Thanks to the organizers of this 11th edition of IMBARK. IIM Lucknow got introduced to this organization last year through similar activity on sustainable healthcare. A 2-day summit we organized with the collaboration of KGMU Lucknow and IMBARK. Dr. Ajay is also here. And based on that experience, as well as our interest on healthcare, we are here today trying to do our bit of activity in the healthcare delivery. So as part of that, this time topic as suggested by the organizers as well as based on our experience. So the topic for today's afternoon discussion is on economics of bridging technology with healthcare. You've heard a lot in the morning, and maybe the entire theme of the session is also on technology enabled healthcare. So we have 3 presentations followed by about an hour panel discussion with the eminent people from the industry, which includes a good mix of both practitioners and also the academicians from healthcare. So with these few words, I request Tino to carry on with her structured proceedings. The first presentation she will introduce. Thank you.
I invite Mr. Sujay Sandra, founder and CEO iQray Software Kolkata, to talk on innovative models of healthcare delivery in rural setting. Experience of an IT startup. Mr. Sujay Sandra has done his MCA degree from IIT Hyderabad and has strong technical knowledge in CRM, analytic business intelligence and R&D, and he has worked for more than 12 years in various IT firms like IBM and Oracle. Sir, please.
Good afternoon, everybody. Hi, I am Sujay Santa. I would like to thank Dr. Sagar, Dr. Deepak Agarwal, Dr. Sanjeev Hoy, All India Institute of Medical Science, IMBARK. I am Lucknow, and especially Professor S. Venkatraman for giving us an opportunity to come over here and talk about our work. So iCure is an organization which started in 2010, around little more than 5 years back, with the sole aim of providing affordable and accessible technology using innovative technology mechanisms. So as Tinu was mentioning about my background, I have worked in IBM Oracle for more than 12 years. And during that time, I was trying to see that how technology would be able to connect the rural patients with the doctors. And then I thought that I need to do something about it, and that's how I founded iCure way back in 2010. From my personal experience, we have seen today where I am standing, All India Institute of Medical Science, which is India's and of course world's one of the leading hospital providing some of the best care. How can we provide such kind of care and that kind of specialization which is available, that abundance of information and knowledge which is available in this institute, how these things can be catered to the remotest parts of our country. We have seen from our experiences that when a patient is walking inside the hospital, all the technologies comes into play, right from patient registration, billing, inventory mechanisms and everything. The moment patient walks out of the hospital, the doctor loses all contact with the patient. And in case the patient has any kind of issues or the challenges, we all know that he or she has a tough time in accessing the doctor for any kind of help or suggestion. So the problem which we are setting up is, doing is we have our 28 rural health clinics. Health clinics are something wherein it's just a 200 to 300 square feet of building, which we partner with the ground partners such as Pradhan, Rotary International, NABARD, who has such kind of existing infrastructures in place in the remote areas. And we have our own medical team. This medical team comprises of doctors, paramedics, health workers, who move about in these areas on few days in a week. And then these patients, they are able to get doctor consultation and medicine at as low as 90 rupees as against 300 to 400 rupees that they have to pay for the same set of services elsewhere. Apart from that, in case this patient need access to any other basic services, for example, BP, ECG or sugar, these patients can avail those services. And we are able to capture all the informations right from the clinical details as well as on the other administrative aspects. And then these data can be shared back to the doctors at any point in time. On the other days when this medical team is not available to these patients in this community, then these health workers, I'll talk about that in later slides, these health workers act as the interface between the patients and the doctors. So they have something called as point of care devices and mobile phones wherein they would be able to capture the necessary details and send it back. So far we have 28 clinics of our own. We have treated more than 32,000 paid patients at our clinics, and we have screened more than 4 lakh patients through our partner network. So this is the basic problem which we have, like it's a 70-30 rule wherein 70% of the population is staying in the remote areas, and in many cases for even the basic primary healthcare services they have to walk more than 5 kilometers, and hardly any percentage of the patient or the population in India is covered by medical insurance. So what is our solution and the technology? We are, our fundamentals is on 3 building blocks. One is on the technology wherein we have understood, like having worked in IBM and Oracle, it was much easier for us to adopt a technology which was available in the developed nations. We did not do that. What we did is we really spent time on the ground wherein we saw that what kind of technologies would really work in the Indian context, be it in terms of disruptive innovation, be it in terms of very low internet bandwidth which is available in our country, how that can be utilized so that the people who are naive users, they have hardly any access to technology know-how, how they can be trained to use such kind of technologies. And today we are fortunate that even a tribal health worker with just 2 to 3 weeks of training, they would be able to use our technology to capture various clinical and other aspects. The other thing is on the skills training, we have understood that it is very difficult to train and deploy manpower from an urban setting to a rural areas. Of course, nobody would want to work in a rural settings unless and until that person belongs from that community. So we have identified the inborn resources in that village. For example, we have identified women population within the range of 25 to 45 years of age, like they're married, they have children, so they are kind of settled in their life and they would want to do something to their community, for their community. So we have been able to provide training to these community health workers. And third is of course on the capacity building wherein we are able to provide the rural healthcare delivery to this community. So with this combination, we are able to provide affordable healthcare delivery, which is almost a negligible cost compared to the services which is available in the country. Now at this point, many would want or have a question like, are we in a competition to the government setup? No. For example, if we talk about just West Bengal, for a population of around 10 crores, we have hardly around 900 plus PHCs available. So we are setting up the clinics or even the fixed or the mobile clinics at the places where nothing is available. So as this is on a technology presentation, I would like to delve deep dive into the technology aspects. For example, in the slides which you are seeing over here, in this, our technology is spread across right from the last mile, wherein the health worker would be able to carry a smartphone or a tablet loaded with the application, and then they can go to this last mile even at the patient's home. So, for example, if the patient is at a village which is across a swelling river without a bridge, through on top of the hill, through the jungles, or maybe at a place wherein it's hardly difficult to reach, this patient would be able to go to the patient's home. They can capture any kind of details. For example, if a patient has got a pain, fever, or any other basic symptoms, then all the follow-up questions related to that would be asked. For example, if it's a pain, how long has been the pain, and other questions, just like a doctor would be asking such kind of questions. And once this, the health worker is able to capture this data, then this health worker would be coming. Once this health worker comes within the internet zone, this data can be synchronized back to the server for necessary action by the doctor. So, for example, once this information is available to the doctor, this doctor would be able to suggest like nothing to worry, change the drug, change the dosage, or bring the patient to the hospital. And on the clinic side, so once this data can be made available at the clinic level, so the clinic level is at a block level, which is a congregation of a village, like it has got access to the road, electricity, wherein the medical team would be able to go, and they have some other additional services such as pathology. So this data can be present over here, and from here, in case the patient need access to any kind of secondary or the tertiary care help, these data can be sent to the doctors at the specialists. So they would be able to go through such kind of information, and they can act accordingly. So in a way, in a nutshell, what we are able to do, we are able to utilize the limited set of doctors which is available in our country, use the technology which is, and then utilize the existing manpower of the community health workers, and then do the remote monitoring and intervention methodologies. So with this, with a very small medical team, we are able to go through such kind of areas. I would like to give another example. For example, we are working in Jharkhand in partnership with Tata Trust. It's a village, it's a block called Torpa, which is one of the most difficult terrain. It's around 3 hours from Ranchi. This block is having around 1 lakh tribal population. And Tata Trust and Pradhan, they have been working in this area for past 15 to 20 years. Giving them on the agricultural practice, how to grow various kinds of agriculture. Like before 2000, these population or the entire Ranchi would have to import marigold, pulses, broccoli from outside of Jharkhand. And now through this entire team, these people have been taught how to grow such kind of agriculture, leading to a good amount of saving for this community. Apart from that, they have been also taught to grow various kinds of livestock, for example, chicken or such kind of things. And then what they have seen is in this past 15 to 20 years, these self-help groups, they are able to save anywhere between 1 to 1.5 lakh rupees in a year's time. And out of that, 50% of that money goes towards medical expenses. More than like 70 to 80% of the families in that area has suffered from malaria. And in such kind of cases, these patients, they do not have any other option but to go to the uncertified RMPs. And then these RMPs are charging anywhere, any exorbitant money, which they, according to their wish. So with this setup, these community members, and then there was a challenge that, okay, we have been able to solve one part of the problem, meaning that we have been able to show a path for the livelihood generation. But if we are not able to provide the healthcare, then the complete support is not being given. When we went with our team and we interacted with these tribal community populations, it was around 100 odd women members within the range of 20 to 50 or 60 years of women who are all waiting and sitting in that particular area. And when we interacted with this community, of course, they wanted such kind of healthcare delivery mechanisms in that zone. To our surprise, we saw that none of these population in that community was having any spectacles. So we asked that, is it possible that none of you have any kind of eye challenges? Don't you have any kind of eye issues? And we asked them to raise hands, and of course, more than 60 to 70% of that community raised hand that some or the other problems of their eye were having the problems. Then we asked that why don't you go to the the opticians or wear spectacles? And then they were saying that they were worried that if they are wearing spectacles, it might fall off, because or they might have to tie a rope behind this. So such kind of knowledge or this kind of population is there in our country still. And then we had to literally tell them that no, there has been a lot of changes, there has been a lot of things, and people are able to use there are new type of things which are available, and you don't need to really tie a rope to wear spectacles. And then we asked a very basic questions like, do you think how many of you are using mobile phones? Of course, like 20% of that community are having mobile phone in their family. And then we asked that, do you think that after this mobile phone, the penetration, have you been able to benefit anyway? And they agreed in an affirmative manner. This means that in the remotest parts of our country, in the remotest parts of the region, the technologies has got an acceptance. Technology has got an approval. So it is a high time that if we are able to provide such kind of solution to this community and to any other communities at large, we would be able to bring a change to the people's lives in a positive manner. So this is another, the diagram which we have on the technology. So this is where what is our core engine over here. So for example, for the sake of the entire audience who, for example, here we have the messaging scheduler, the content server, appointment scheduler. There are various kinds of health trackers. Just to give a use case for this problem, for example, in any block medical office, the BMOH, they have anywhere between 100 to 200 to 300 ASHA workers. And it becomes a very, very difficult task for this block medical officer of health to really track down the activity, the zone, and in which they would be able to work, what kind of reporting that they are able to do at the end of every week. So we have developed and designed a solution wherein we would be able to track and monitor these ASHA workers in a certain fashion. And in case, even if these ASHA workers are, in some of the difficult zones, most of the difficult zones, for example, be it in Assam, in Dimahasa, where we are working, this is one of the hill district in Assam, where in more than 4 to 5 months of the whole year, this entire community gets due to the landlocked because of the monsoon season. So we are able to work in certain regions, and we have been able to create several kinds of engines. For example, once this health worker is capturing this data based on the various rules engine, you would be able to write, and you would be able to send certain amount of flags. These various flags can go to the doctors at the right time. Now, the most important part of our the whole organization structure is the community health workers. So we have seen the usage of such kind of workforce in various settings, be it NGOs and others. Our USP has been that how we would be able to really design a very innovative model wherein these community health workers, they are able to use technology. And for this, for example, here we are working with University of Michigan as well as several other organizations. In this, what we have been doing is that, for example, when we took such kind of tablets and smartphones, this was around 8 to 10 months back, and when we gave it to them, we saw that these women were kind of really shivering. They were very, very, hesitant to hold such kind of gadgets in their hand. And these community members, they are like, as I have told you, like 25 to 45 years of age, women married, and they did not have the mobile phones. Most of these mobile phones were carried by their husbands or the male members in the family. And when we gave such kind of devices to them, they were really apprehensive to use such kind of devices. And then we had to do a lot of scheduling. We had to tell them that no, even if it falls, doesn't matter, but if you want to use it, that can bring an opportunity for livelihood for you. And when we shared such kind of things, then we were able to see that these women were able to get some kind of confidence within themselves. So in this case, what we do is that we identify such kind of community members. We train them on the various clinical aspects for around a 2 months training, wherein how to do the patient history taking, how to capture various kinds of vitals, and also on the technologies like how to capture various data, how to open an app, how to feed the various details on the phone, how to feed, escalate or refer patients at the time of need. So we have trained on all those aspects. And today we have got more than 30 such health workers who are in the community, who are confident to use how to use the technology and go to the most deep regions of our country. For example, now these community health workers are working in Jharkhand. They are working in West Bengal to detect the high risk pregnancies as well as the early child development for the infants of 0 to 25 years of age. And also in Karnataka, in Haveri district, where these community health workers have been trained and they are able to adopt such kind of devices. In addition to that, we have also are working with several organizations wherein we have come up with some kind of a medic bag. So this medic bag comprises of the various essential point of care devices such as BP, ECG machine, sugar testing machine. So whichever machines which are affordable are portable in nature, these devices can be carried by these community health workers in the community. And then once these community members are in front or having an access to the patients, they would be able to capture this data, and the doctors who are sitting at an hospital or a clinic, they would be able to reach out to this population through these health workers. So these are some of the screenshots. For example, the first one is in Bengali, the second was in here. We are using this first in West Bengal for the mother and child care intervention in partnership with University of Michigan. The second one we are using in Hubli, Haveri district in Karnataka in partnership with Deshpande Foundation for the mother and child care. So this is how it is language agnostics, and these community health workers, they can really easily adopt to such kind of simple and easy to use technology for capturing these data and bringing it at the right time for the patients and to the doctors. When we intervene to the doctors, we would like to share some of the various glaring examples. For example, when we showed that we were working in an area and we saw that these mothers, the pregnant mothers, they were very highly anemic in nature. Like already they had 2 children and their hemoglobin count was less than 9, and she was carrying the 3rd baby. So then we asked that why these kind of information are not available to the doctors or the gynecologists at the right time. So some methodology, some platform needs to be there wherein we would be able to capture such kind of informations and be able to escalate these informations to the doctors and the specialists at the right time. Then only we would be able to kind of focus on the prevention of MMRs and IMRs. Next, we would like to talk on the convergent innovation. In my experience in the past 5.5 years while working in iCure and also interacting with several organizations and others, we have understood is that in the community healthcare and public healthcare delivery aspects are very different from in a hospital setup. For example, when it comes to community healthcare, this healthcare alone cannot be singled or phased out in a different way. Healthcare is very interlinked with health, water, sanitation, nutrition, cultural, social. So many things are interlinked to each other. And if you want to address such kind of things, we really have to think in this entirety. That how do we address such kind of things? No matter if a doctor and the doctor is able to give a medicine or a pill to prevent such kind of diseases or any kind of disease, then we have to see that what kind of other social or cultural aspects are also linked to each other so that these problems do not recur. For example, in Kandhamal and Raigada, these are the 2 most southernmost districts in Orissa. Here we have been working on the convergent innovation in partnership with McGill University, Canada, EFRI Washington, and Pradhan, which is a large NGO. And we saw that the population, more than 90% of the population were anemic in nature. What is the solution for that? Can we solve such kind of problems using iron and folic acid? Maybe there are something else also which is hidden. I would like to ask to some of the the most specialized persons over here that how do we deal with these problems? Then we figured it out that the staple food, the basic staple food which they were having did not have the sufficient nutritional aspects which can focus or eradicate such kind of things. So through agricultural intervention, we were able to ask them to grow pulses, millets, and other things, and then these becomes a natural supplement to their diet. And then we have seen a positive result in the whole thing. So on the organization reach, as you can see over here, so we are present in West Bengal, Odisha and Karnataka, and we are soon expanding in various other parts of our country, for example, Assam, Meghalaya, Tripura, again, some of the various difficult to reach terrain and using technology. Now we have been, getting around 2,000 patients in our network through our partners as well as our clinics, and we are aiming to reach out to more than 5,000 patients per day on an average basis by end of 2016, and which we are hoping to grow up to 8,000 patients per day hitting to our network. These are some of the data snapshots which has come up. And when we have been, providing the healthcare delivery, our aim has not been only to just provide the doctors and medicines and, just be happy about it. We have been thinking that how do we link from point to point? How do we link from end to end? For example, be it from the cases of anemia, hypertension, diabetes, and several other aspects. What kind of aspects or the behavioral change needs to be there from a patient-centric to a population-centric? Can we think from a population at large? Can we think from in the entire village or the entire block at large? Like what kind of food habits, what kind of social things, what kind of other aspects has to do with the healthcare? And when we have thought on those aspects, we have seen some positive results. So some of these analytics which has been captured through our technology, we have seen what kind of top 5 diseases are there in a particular area from this, maybe from this quarter to that quarter. And when we have been working with people like World Bank and several other organizations, there has been several questions even from the top corporates wherein we execute the CSR projects for various corporates. We have seen that even though there has been a lot of fund which is coming up, we have been, we are trying to see what kind of impact we are creating on the community. Let's say a fund of X amount has come in the year 2014, and this fund has been utilized in a certain particular case. Vis-a-vis what kind of diseases were there in 2014 to what it is now, and what kind of predictive modeling can be there in the future. So when we try to draw a comparison, we are able to see and focus and pinpoint on some of the most prevalent diseases and what could be the means and methodologies. So once we have this kind of available data, we are able to take it to the various kind of specialists to seek their advice and suggestions that how to deal with such kind of problems. So on our future plan, we definitely would like to, build robust methodologies and see that how we would be able to come up with various kinds of predictive modeling, wherein we would be able to answer that in 2016 in the monsoon season in this particular block, we have seen maybe 40% of the cases suffering from malaria. Maybe that should come down to less than 30%. This kind of predictive modeling would definitely help for better, effective resource utilization, be it in terms of the human resource, be it in terms of other financial resources and others, wherein we would be able to pinpoint such kind of problems and eradicate these things in a step-by-step manner and in a phased manner. These are some of the awards and recognitions which you have got, some of the pictures from the field. Thank you. Any questions here?
One or two quick questions.
I think the idea of carrying a tablet to the patient is a very good idea at the level of a PHC worker. The data which they are collecting at that point needs to be brought back before it can be shown to a doctor, or is it possible in those remote areas to access that data via satellite to the doctor?
So once the data is being fed by the health worker, this data, once the health worker comes within the internet zone, this data gets automatically synchronized to the cloud. And then whoever is having access to that information, be it the doctor or the patient care coordinator, they would be able to go through that information and advise accordingly.
So these PHC workers will not be able to help in an acute emergency situation?
Right now, this kind of model is not in an emergency setup. This is primarily to do with the preventive and the primary healthcare delivery mechanisms, because it takes a while for the data to come to the doctors for this such kind of things. But at least within that domain also, we should be able to treat a large amount of diseases which are of such criteria.
Have you done any work at the urban PHCs?
We have not done work on the urban PHCs, but we have been working for the construction workers in the cities to save it. So we have seen several aspects in the construction workers, what kind of diseases, what kind of prevalence that they have, so that we have worked so far. Yeah. Yeah, yeah, that is possible. The video integration is possible. Yeah. Yes. Yeah, it is there. So we do a Skype integration. That is linkage. So through that mechanism, we are able to do that. Okay. Thank you. Thanks a lot.
Thank you, sir. Our next speaker is Mr. Sachin Gore. He has a double MSc in mobile security and cryptography and is involved in multiple ventures in the domain of digital marketing, mobile solutions, and Internet of Things. He was in top 10 innovators in India under India Innovates Growth Program 2013 by FICCA. And he'll be talking on rural healthcare ICT intervention for improving mother and child health. Sir, please.
A very good afternoon to everyone. My name is Sachin Gaur, and I really want to thank you, this audience here, because I'm a non-medical person, and here there are a lot of medical people. So I hope I am able to create value here, and also thank you, Professor Venkat, for giving me this opportunity. So I am presenting today, a work that has taken us around 3 years, and I will take a slightly different angle than medical, which is more about rural communication, and I'll share with you why is that, and also I'd like to thank previous speaker, because he has set the stage in a way that I don't have to talk a lot about those things which he has already shared. And our work is related at the PHC level and to the outreach to the last mile. So it's in a way very complementary to the work your organization has been doing. So our work is actually, it's more like a case study that I'm presenting to you today. It's from the district of Sabarkantha in Gujarat. So Sabarkantha, it recently got divided into 2 districts. Previously it had around 2 million population, and now it has around 1.3 million population. So this solution that I'm presenting to you today, it caters to that number of people. So, around 3 years back, we did a field research in Andhra Pradesh, and I personally did few thousand kilometers of, survey and research work with rural people. And I really want to leave it as an important learning for anybody who wants to work in the rural sector. One is that India is a country of oral tradition. So when I say that, we focus a lot on building IT solutions, but we somehow do not try to make them easy in a way that can we make them literacy neutral, as in to participate. For example, our friend mentioned about community health workers. So they can have various level of education, right? So this is a strong message I got, and I also found this quote from Professor Anil Gupta very beautiful. Every time a villager dies, an entire library is burned. Meaning, that the knowledge which is there, it's there in our head, and we are not documenting it because we are a country of oral tradition. It's gone after the person dies. Then the second point also I want to illustrate is that people want to learn from each other rather than learning from books. And then the kind of communication solutions that people are bringing to them, they don't want to pay for it. You know, like the missed call phenomena is out of India, like now taken up by few companies and already quite successful. And they also want those solutions to work offline, because internet connectivity can be an issue in the rural areas. So I just wanted to, set this kind of guiding principles that I discovered in the process of working on the rural areas. So basically, we started, building prototypes with our foreign collaborators, in this case, Finland, and that gave us a lot of, learning that what kind of user interface it should be. Should it be more pictorial or should it be more textual? So, images and videos work best, and this is, where I come to our final solution, which after a lot of research and a lot of prototyping we end up with. So basically it's an Android tablet, and the entire solution is in Gujarati, which is vernacular font support. So today if you go and buy a tablet, Android tablet, which is expensive, so it might support Indian fonts. But if you go and buy a cheaper device, it will not support fonts. The first challenge was with us that, we were doing this work with partnership with District of Sabakanta. So they didn't had so much budget. So we have to travel, and find, people who could provide us hardware which is cheap and also could support Indian languages. So that was the first challenge we had to solve. And it was needed to be solved because people in those areas, they really wanted whatever communication that we do, it is to be done in the local language. So that was, one small breakthrough that we have to make. So basically in the end, we were able to find a very cheap tablet company. They were supporting all the Indian languages. So once we built this solution, it took us a while. So it was, so let me just quickly summarize what this product does. So this app, basically an Android application, which has video and audio content and very visual content on mother and child health. So it has around 110 topics, covering various situations and scenarios, and it's easy to navigate. So any health worker can go and navigate basis the communication with the beneficiary, that whichever, if their issue is anemia, they can show them a video about anemia, for example. Not only that, they can show the content. They also have a multiple choice quiz. So if you can see on the left hand side, that green and blue icons, so they are basically topic based quizzes. And we have also built a gamification feature in it, wherein if a ASHA worker or a female health worker has this tablet, and if she is using it for, doing the outreach, she gets points for it. So there are various features. Let me just show you one by one. So I covered already that it has local vernacular language. Then it has also giving a capability for the district administration to get all the data in real time from the ground and see the performance of all the ASHA workers. It also has a capability to run offline. So if the data connectivity is not there, so all the, the healthcare information is available offline through an SD card. And as I said, that there is also a feature of gamification. So through the dashboard, we are also able to empower the health workers to, compete with each other. This is a glimpse of the dashboard, how the IS officers can look at it, or the district administration people can look at it, that what kind of reports. So it's in some ways it's very similar to what Sujoy already presented. What ways it is different, I'm probably then we have to discuss with each other, but I think gamification is one part, and we are making it run offline, whenever possible. And in that district they have Wi-Fi zones, so whenever these health workers are going to PHC, they can sync their data. So when they are out in the field, they don't necessarily have to have internet, but they can do all the report collection or information dissemination. They can come back and sync it with the Wi-Fi zone which is there in the PHC. So this product was launched by Mr. Modi when he was Chief Minister in January 2014, and since then, we have been monitoring and improving the product. So it took us, some time to get it up and running, because like my friend mentioned about the community health worker training. So one is building the solution, the other part is really working with them. So from a health workers point of view, they are using it to disseminate health information. They are enhancing their own knowledge on new and old health topic, and also they are able to send reports which are geotagged, so we can actually do a lot of analysis on that. And as I mentioned about the interactive quiz, that also makes that conversation between them and the beneficiary very interactive. For the government, as I mentioned, it allows them to track and monitor performance of health workers. They can also remotely push new content. Let's say there is a new epidemic. Right now, for example, in Delhi, dengue is one such example. Now government is spending some money on advertisement. So imagine if, in a hub and spoke model in a rural district, how you do that. So you can actually, make a new module and push it, and all those around 500 health workers, they can get it as they sync their device. And as I said, that there is also some, gamification which allows them to, incentivize the health worker, and it also scales their training efforts. So this device, right now is with the people at PHC and with the health workers, and it's catering to the geography that they have. They are assigned to like the PHC villages and all that, and also the district administration is using it actively to monitor the progress. So these are some pictures from the community, the female health workers doing the training for first time. So in the project when we started, not a lot of stakeholders were there, but as the project get stronger, now UNICEF is on board to do a impact study, and there is also a medical college which is doing vetting of the content. So now we have actually variety of stakeholders, from a medical college to hospital to UNICEF to the district administration. So it has become a very comprehensive package. And Professor Singh was with me recently, and what has happened on the sidelines, when these women, which are mostly middle-aged, they are getting such a device for the first time, it has actually given them a lot of empowerment. That's a subtle part of it which we don't cover usually, but it was very heartening to see and listen to their own stories. So I decided that I should play a video, which is a very small video, only 2-minute video, for this audience to listen to a testimonial from a female health worker who was using this tool, and she encountered a patient whose newborn kid were suffering from malnutrition, or they were underweight, and they how she used this tool. Maybe you would like to see that. So it's in Gujarati, but you can read the text.
એડમિટ કર્યો એનું લગભગ 40-45 હજાર ખર્ચ ના બચ્યું. હું અહીં આવી ગઈ તો પછી જે ઘરે હતું ને એનું પછી મેં ના જ પાડી દીધી કે આપણે બહારનું આપવાનું નથી. માતાના બ્રેસ્ટફીડિંગના ફાયદા ટેબ્લેટ આખું વધારે. એ જ બાળકનું મેં કાંગારું ખાસ કાંગારૂ કેર વિશે એમને સમજાય. મમ્મી અને હું મોટી બેન આખું આપણું ચિત્ર બતાવી અને એ લોકોને સમજાવી. એ કાંગારૂ કેરથી એ માતાના બ્રેસ્ટ ફીડિંગના ફાયદાથી જે આખું ચિત્ર બતાવ્યું એનાથી પેલું 45,000 ખર્ચી હોસ્પિટલમાં રાખ્યું તો એનું ડેથ જ થયું. આને આપણા મેં રૂબરૂપ કેવું ચિત્ર સાથે બતાવ્યું લાભાર્થીના મગજ એની ઉંમર કેટલા એ લગભગ કેટલા દિવસની હતી 28 દિવસ તો મેડિસ્ટારમાં એડમિટ કર્યું યશમાં એડમિટ કર્યું અને ના બચ્યું. અને આને સર આપણું જ ટેબ્લેટથી ચિત્ર બતાવ્યું બ્રેસ્ટ ફીડિંગ આ રીતે કાઢી નાખો આ ફાયદા છે કાંગારૂ કેર આ રીતે આપવું કોઈ પણ આપી શકો ચિત્ર સાથે રૂમ મેં ચાલુ કરાય રૂમમાં લાઇટ અને બધું જ આપણા ટેબ્લેટથી જ બધું મેં એનું બતાવ્યું. એ લોકોનું હું કહું એનાથી ચિત્ર જોઈને જલ્દી બધું ખ્યાલ આવે. હા.
So this is the first part of the video where this lady Rekha Ben Patel, she was explaining that there was a module of kangaroo care which she used to explain to the mother whose one son already died, and yet despite of being admitted in a hospital and pediatrician recommending some powder, but she was recommending mother to use breastfeeding, and they were able to save this one child. So she was, I mean, when we met her, in our recent trip, so we found her, very excited about this tool and how she could save one life. So, I mean, that passion and that zeal, if you see really in the people who are not very, medically, they're qualified, and they are able to use this kind of a standard tool and bring out a standard messaging and save lives. It really, was heartening to see that. And there's a small, so I just extracted this video from a longer video. That's why I'm showing you in parts. So for us, a success of building such a tool is that to see real lives being saved, and also important this, because everybody relies on this health workforce because it's such a huge number in India, especially sitting in a place like Delhi. These numbers are mind-boggling that we have around 1 million, community health workers. But how do we empower them? How do we make sure that they feel very excited about their work? It's not a burden that we are creating on them. I mean, in our recent survey, we realized that the Anganwadi worker has to fill 11 registers. The same information in 11 registers manually she has to fill. So the amount of effort, they have to make for the reporting system to work, you can imagine. And that's where IT can help. But it should be done in a way that, it is making them part of the story. It is giving them credit, and it is making them feel happy about their work. So this work was also covered recently by BCG in their report for World Economic Forum. And I also want to share another small example that we are working on right now in the same district. So the IS officer told us that in the Anganwadis, these kids which are getting free food, so he is spending a lot of money on this food, but he has no trackability whether this food is getting to these kids. So in our office, we started working on a prototype. You could see on the right hand side, my colleague is standing with a tablet. So it's a research prototype. So basically it's a stainless steel frame that you can see. So what we envision here is that a kid can stand on this kiosk on a daily basis as he or she goes to the Anganwadi, and we can get the height, weight, and the middle upper arm circumference. So initially we were not having MOAC, but the Chief Minister really wanted this parameter because as per WHO, this gives them the malnutritional, classification. So this is another small example. If we can, provide this kind of a kiosk in every Anganwadi in that district. So in real time, on a daily basis, we can monitor the growth of those kids, and we can really know how many of them are malnutrition. So in the end, I would just like to give you, also credit to the IS officer that we have been working, and I highly recommend if any of you want to trial or test any such innovations in rural health, Mr. M. Nagarajan is very forthcoming. So this is it from my end. Any questions I would like to welcome. Yep.
Can you use this mic, please?
Sabarkantha of Gujarat, one of the most remote districts,
Yes, ma'am.
farming districts of Gujarat.
Yes.
And I'm sure even the people there are also very, very like primitive in thoughts.
Right.
So initially, when you introduced this application to these the ASHA workers and the health workers, as you already know, that she already has a huge task.
Correct.
11 registers, 12 registers.
Right.
Plus there is HMIs to be filled now.
Right,
As per
ma'am.
the GOI. MCT is to be filled now by the GOI. So there are a lot of data sheets that need to be filled.
Yeah, a lot of
This
pressure.
is another sheet which is coming in,
Right.
So
Right.
wasn't there resistance from their end to accept it?
So first of all, thank you, ma'am, for asking this question, because it allows me to go a bit deeper, which I didn't cover in my presentation. So the credit goes to the IS officer. So what he did, he didn't want to launch the initiative just like that. So first he thought, we have to create a feeling of team in the workforce, because most of this workforce is decentralized and doesn't have a spirit of, working together as a team. So the project's name is Swasthya Samvedna Sena. So when Mr. Modi was there as Chief Minister, initially we named the project as Pink Army. So we wanted to give them a feeling of like Indian Army, very uniform, very disciplined. So can we give them a brand? So the idea was first to give them a brand. And so we were calling them as Pink Army. Now they have given a Gujarati name to it, Swasthya Samvedna Sena. So the idea was that for all these people that, first we empathize with them and then we co-create the solution with them, instead of, forcing something, which we think is better and they should be using it. So then we partnered with a NGO, Namaste Life. So there's a doctor, Dr. Meena Shah. She is a TV personality for last 20 years in Gujarat. So she's a pediatrician also. So she created all this content. So most of the videos are in Gujarati, where Meena Shah is speaking, right? So if you look at different facets, it took us a lot of time, 3 years now that I'm speaking, to make this thing work. But if we are able to convince all the stakeholders, and these female health workers were really important. So now if you see, from a CM who has become PM to launch the project, and the Mr. Modi himself gave away the tablets to these ASHA workers, I think that is acknowledgement to them. And even when we are going now, for example, now we made this testimonial video. So you can imagine that's giving credit to that lady Rekha Ben Patel, because it's actually her work. IT or our system is only 1% to the system, but it's actually her efforts in saving the life of that child. Thank you.
Congratulations, Mr. Sachin. Hello,
Yes,
Mr. Dr. Ravinder Alot. Congratulations, Mr. Sachin, for such a tremendous job. I have just one objection to your video. ASHA worker criticizing a pediatrician is not the message we should flash.
No, sir, that's not the idea here, but
But you are
can
doing
imagine
it. But you are doing it knowingly or unknowingly.
Sure, sir. I apologize for that, but the intention
You
was
can
not
remove
that.
that part.
The intention was to show that
If
breastfeeding.
a ASHA worker can handle such cases, then maybe we don't need such a large medical colleges.
No, sir. The idea is not that. The intention was maybe.
But message is contrary to what you are saying.
Right. Thank you.
there is a small announcement. Our third presenter is supposed to be from Sir Gangaram Hospital. How they were adapted to migrate from conventional to cloud. Due to some emergency, the most wanted speaker has to be in the board meeting. So he is in the board and his proxy is on the way. So anytime in next few minutes, maybe already inside the campus. So I extremely request with a kind of special request, wait for next couple of minutes. I thought of even preponing the tea break, but the tea break, that guy is also maybe prepared only at, this is the real logistics difficulty. So kindly bear for next 2-3 minutes and we will start our panel discussion as per the time.